Welcome, everyone, to the Aspirational Healthcare Conference. I'd like to share a story that I think helps frame my perspectives as it relates to this critically important area. And on this day, I was headed to the location. I was in my suit in the back of an Uber, and the driver asked me what I did for a living. And I told her that I work within healthcare as a consultant. And she said something amazing to me that I had never heard in the wild. She said, "Oh, I love my healthcare. I love my healthcare. And I'll never leave my current employer as long as I can keep it exactly how it is right now." I then, of course, leaned forward and I told her that. I said, "I've never heard anybody say that before, just, out in the United States. What is it that you love about it? What is it that makes your healthcare amazing that you would say that?" So here's what she said. She said, my doctor knows me. I feel like he listens to me. He knows me. He knows my children. And I know that if something goes wrong, he'll know where to send me so that I'm going to be okay, so that I can go to a really good doctor to help me, to take care of me. And I sat back in my chair there in the back of the car, and that was and it was a moment of reckoning, because I realized I was absolutely grossly overpaid. It's like, of course, that's exactly what makes amazing healthcare, right? A great relationship with the physician, having trust, knowing where to go, and having it be affordable. We all intuitively know what aspirational healthcare looks like. But just because we know what we want doesn't mean that we know how to build it, or that we know exactly how to get there. And that, to me, is what's exciting about this conference, is that we have the opportunity to come together today and tomorrow to learn how to get there, even though intuitively we do have a sense, of sort of kind of North Star of where we would want to be and what we would like to have. And this is about charting the journey to be able to be successful. Now, of course, the question becomes, well, where do you start, right? Because I know what we have now and I know what I'd love to have, and there's a pretty wide gap there. Well, the concept there is that we look at the gateway to healthcare, which I would characterize as the place where we get our primary care. That has been a central focus in lots of places. The primary care really is the heart of the industry. Good primary care being what we would seek to have. And the problem is that good primary care seems to be under assault. And I would say that good primary care necessarily includes an alignment of incentives between the primary care provider and the patient. And anything that disrupts those incentives starts to erode the value of primary care and puts at risk its ability to deliver a promise that is truly aspirational. I used to look at direct primary care, for instance, as an area that is safe, that does align the incentives of the provider and the patient. And even while independent primary care has been getting acquired and gobbled up, good, safe, direct primary care has been increasing significantly. So there is a great answer that is sort of coming more and more into the mainstream. What we're getting at here is how many people actually go to primary care. And I said, admittedly, only about half. He said, that's right. About half of people, I'm paraphrasing, will go to primary care, but the other half, primary care has to come to them. And there has to be a way for us to compensate the outreach that must occur to reach about half the population who won't voluntarily, for whatever reason, hop into primary care. And he said the goal isn't just to have a provider there when you need it. The goal is that for every person, they have a relationship of trust they can rely on. Wanted also to express appreciation to the American College of Preventive Medicine for what they've given to this conference, and wanted to give their president Dr. Tonette Krausewood a couple of minutes to introduce the college.
Thank you so much for the opportunity to speak with this impressive audience today. As a board-certified physician in preventive medicine and president of the American College of Preventive Medicine, I wholeheartedly support a preventive medicine foundation in the forefront of healthcare. I have experienced the benefits of this approach, and I've also seen the consequences when prevention is on the sidelines. There is currently increased attention on public and population health, coupled with a call to action to realign our investments in our overall healthcare infrastructure that support in community engagement with implementation of evidence-based prevention strategies and to build a strong public health workforce, all signaling the enormous potential for healthcare organizations to transform their approach to improving health by focusing on healthy behaviors, prevention, and wellness.
Sounds great. Thank you very much, Lee. We'll start with introductions. My name is April Kyle, and I am Alaska Native, Athabascan, and Russian on my father's side. That means I'm a customer owner in our healthcare system. I've had my babies here, and so I'll speak to our system both as a leader and also as a customer owner who uses our system. Doug, do you want to introduce yourself?
Hi, Doug Eby. I'm a physician executive. I've had the incredible privilege of working here and partnering in support of Alaska Native people and their journey to transform healthcare for 30 years, particular position for 26 years. And it's my incredible honor to join April in telling you our story.
Perfect. So we had a chance to chat with Lee before the session, and I just have to say, the topics, Lee, that you brought up in your introduction are really going to align with what we're doing in our healthcare system. I'm excited about that. It feels like we are in shared space in how we are thinking about healthcare transformation. You might be wondering why this little healthcare system in Alaska is the example that you're looking at today. In some of our presentations, we have slides and slides and slides of data, but we thought we'd start with just one sort of so what slide. So our story is about sort of whole system healthcare transformation, and as we've walked through this journey, we've experienced significant decreases in ER visits and inpatient visits. We have 97% customer owner satisfaction, and that's really important to us, as you'll understand when we share our story. 95% employee satisfaction, and then just around HEDIS measures, which are the sort of comparable healthcare outcomes measures. When we started this journey, everything you hoped to be high on, Alaska Native people were low on. And everything you were supposed to be low on, Alaska Native people were high on. And we've been on a journey to redesign our healthcare system, and it's resulted in our outcomes being sort of best in class, all at the 75th percentile, and many now at the 90th percentile comparators nationally. A key part of understanding our system is this word we use called customer owner. So you are probably used to, when you receive your health care, being referred to as a patient or a client, maybe a member is a word that your insurance company uses. And to us, all of those words reinforce the traditional hierarchy in healthcare. So there's this hierarchy in healthcare that says that doctors and healthcare systems and insurance companies really run the show, and that people and families just come in sort of as recipients of something. And for us, we're really looking to challenge and break that hierarchy. And so we want to create a relationship where we sit in partnership and walk together. And we say, thank you, doctors and healthcare professionals, for bringing your expertise. Please sit in relationship and partnership with aunties and uncles and mothers who also bring their expertise to that relationship. And the word customer owner to us helps us frame that. So words matter, and the people who come in to receive care in our system are both the customers in the system, and at the same moment, they are the owners of the healthcare system at large. So we have this set of goals, which are sort of the values of our healthcare system. And before I talk about these goals, I just want to share with you how we think about our vision and our mission. So our vision is a community that enjoys multidimensional wellness, physical, mental, emotional, and spiritual wellness. We think those things are interrelated, that they're connected to each other, and that there is this false notion in healthcare that we're going to take care of the physical wellness, but don't worry, because there's behavioral health. It's in a building over there for that one uncle in your family, and you can go there at 2 o'clock on Tuesdays. And that separation of mind and body, we think is just incredibly harmful. So we imagine that the healthcare system's job is to understand that wellness is multidimensional. And then how you get to that multidimensional wellness is by sitting in relationship and in partnership at a macro level between healthcare system and community, and at a micro level between care teams and families. And our system is about more than just diagnosis of illness. It's more than treatment plans. It's more than prescriptions. It's about that last phrase, physical, mental, emotional, spiritual wellness in individuals, families, and the community. At the beginning of our journey, when we transitioned from this government-operated system and we gave control to community, community was going to run the system, we asked community, what do you want out of a healthcare system? We interviewed patients in waiting rooms. We interviewed people who worked in the system, elders, youth. We did focus groups. We partnered in a research study around this. And these operational principles are what we heard. What does it look like if you could create a healthcare system for your family that would deliver to you what you believe you need? And you can sort of see this list. And this became our marching orders. Now, our system recognizes that there's no right way to deliver healthcare. Instead, the right way to deliver healthcare is to create the competency of listening to community and allowing community to drive what that healthcare system looks like. And we did that sort of once in the beginning, and then we do that continually over time, so that the system that my kids need and my grandkids will need will be delivered, because they will be in charge of directing how we're innovating in generations to come. And that's a core competency of our healthcare design. So we create this idea of core concepts. We talk a lot about behaviors, like how do our behaviors impact our wellness? Well, core concepts for us is about our behaviors within healthcare, within the organization, within the delivery system. So if I was to walk into a clinic and be able to be invisible so that nobody notices that the CEO has walked in, I would look to see people who are working together in relationship, encouraging understanding, listening, laughing, noticing, engaging, sharing. And it doesn't say people are, producing high volume services and meeting sort of revenue targets. It says that we're together as humans in a real and genuine way. Core Concepts is also a 3-day training that's led by me for every new cohort of employees, where we take this idea of sitting in relationship, care team relationship with family, and we start to practice that. We start to, it's based on the idea that relationship is developed when we're comfortable enough to be real with each other. And if I can open up a piece of my heart and share part of my story with you, and you can receive that in a healthy way and share part of your story with me, that connection that we've created as we share that story is the foundation of a real human-to-human relationship. And we can start to value each other. I, as a mom, can value your expertise, and you as a provider can value my expertise. And we want that to be the core of how we recreate the idea of hierarchy moving to relationship. And we're very intentional about how we onboard the people who work in our system to be able to function in that way. So we think this idea of being in relationship, that is the core competency of our healthcare system. The thing that we are producing every day is improved relationships that exist internally between teams and infrastructure programs, and externally between the system at a micro level with families and at a macro level with communities. And we're doing that sort of all the time. We have an intense focus on creating ways that we as leaders are collecting the input and the voice of customers and engaging customers in being the driver of how we are doing continuous improvement. And so Doug and I spend, I don't know, hours and hours every week specifically in community engagement efforts, listening to tribal leaders, listening to health councils, understanding the perspective of people who are receiving care, and more importantly, understanding what's happening for them in their lives that impacts their wellness in order to think about how the healthcare system can partner in their lives. So our story really is about whole system transformation that's based on understanding the perspective of customer owners and employees, and being willing. So on the left is the old IHS hospital I went to as a kid. Being willing to decide that that old model isn't okay, and that we're not just going to tinker around the edges and call it improvement, that we're going to reimagine the vehicle of healthcare to be something that is completely different. And we're going to do it not by being driven by our payers or what regulates us or our accreditation, but being driven intensely by the needs and voice of the community who receive that care. And then we'll figure out the legal and financial world behind it, but the intention is to design something very, very different that's based on voice of customer. So with that, I'm going to pass the next section to you, Doug.
All right, so we are going to get to system design specifics in a few minutes, but continuing on the theme of what underlies the difference for us. The reality is that the current medical system is based on particular assumptions, a particular medical culture, and what's really distressing to us is no matter where we go in the world, so in single payer systems in Europe and Canada, Australia, New Zealand, Singapore, the medical culture is pervasive and drives everything regardless of the financial environment. So the idea that you get the money right and then somehow magically you'll get a great system is a false assumption. In our system, no one pays any out-of-pocket costs. There's no co-pays, no deductibles, no out-of-pocket expenditure, and you don't have to have that to shape behavior by people on the receiving side. So money is misunderstood. The U.S. has managed to screw up the money side of things worse than anyone else ever in history, but even in single-payer systems, the medical culture is pervasive and drives the design of the system, which is extremely unfortunate. As April has already said, this idea that centers of excellence, so medicine's obsessed these days with high reliability, protocol standards, centers of excellence, best practices, organ-specific and specialty and subspecialty things and so forth. The problem is, especially if you're a little bit older and complicated, you go to 5, 6, 7 centers of excellence. Who's the coordinator, integrator? Who's the coach, the mentor? Who's the partner that pulls that all together and helps make sense of it and supports you in your journey? And it's the people least able to do that on their own who are in the population subsection that drives the majority of costs. I think everyone knows this, but 5% drive 50% of cost, 20% drive 80% of cost. Healthcare consumption is not evenly spread across people in society. So just on philosophy, a couple more slides. So this is very simple, but I think it's extremely important. In a high acuity environment, so if I get hit by a car on the street, the EMS people do things to me, the ER does things to me, the operating room does things to me, the intensive care unit does things to me. That's high acuity, and the system has the power and control, and the patient, the customer owner, the family have relatively little control. But in the majority of healthcare these days, somewhere around 2/3 of the money and the effort and the staff are in the consequences of people living with chronic conditions. And in that environment, it's not whether we want it to be true, it just is true that the patient, the customer owner, family are in control of the majority of the variables and therefore the cost and the outcomes. So whether they pick up their meds, how they take their medications, whether they take all their medications, whether they have side effects and quit taking their medications, where and who they get advice from, it's all under their control. What they eat, how they sleep, tobacco, alcohol, drugs, how they relate to each other in family units, what they do with anger and frustration, exercise, sleep habits, all these things are under their control and drive somewhere between 80 and 95% of the variables that drive cost and outcomes for 2/3 of the costs and outcomes in healthcare these days, especially those things that employers care about: healthy, happy, capable workforce and the work environment. So another way to say the same thing is this example from complexity science. If I stand one place and I have a bunch of rocks in my hands, I can eventually hit a target on the wall every single time. The rocks are passive. I can make them do what I want. I can best practice, benchmark, I can get coaching, I can measure, I can analyze, I can apply Six Sigma, Toyota production system theory. Eventually I can make the rock hit the target every single time. But if instead I have a live bird in my hand and I want the bird at the target, I can throw the bird with force and it'll go the way I want for a little bit, but then it takes control. It flies where it wants to go. And if the bird is attracted to its bird babies or bird seed or the telephone wires or trees, it's more likely to go there than my target, which may have no value or relevance to the bird. So this is healthcare, right? High acuity is like throwing rocks. They're passive. We do things to them. But as soon as they're in control, it's like the bird. The bird's going to go where it mostly wants to go. So we have to either make the target we value attractive to the bird, or more importantly, we need to move our target to where the bird already wants to go.